Hey guys, I have a new video that popped up in my feed and I cannot wait to watch it with you. This is from Dr. Brad Stanfield, a PCP down in New Zealand, who is telling us that 99% of people who have heart attacks have this warning sign. Let's find out what it is together.
On July 20th, 1984, Jim Fixx, the man whose best-selling book on running had inspired millions of Americans to get in shape, dropped dead of a massive heart attack during his daily run on a quiet Vermont road. He was 52, he'd quit smoking, he'd lost 60 pounds, and he ran 10 miles a day. It's the kind of story that makes us all quietly wonder, is it possible to do everything right and still have a heart attack come out of nowhere? And for a long time, the research seemed to say yes. Between 11 and 23% of the most severe heart attacks occur in people with none of the standard documented risk factors. So no high blood pressure, no high cholesterol, no.
I think I'm going to fact check this a little bit later because one of the more recent articles I've seen actually shows that about 90% of people who have major adverse cardiac events have one of the classic risk factors. But let's go through the rest of this and then see. We'll circle back to what we think the attributable percentage of folks who have no risk factors is at the time of their heart attack. So let's keep going and we'll come back to this idea in a little bit.
Diabetes and a non-smoker. So that number was alarming enough that cardiologists gave it a name called the SMURF-less phenomenon. But a major new study of more than 9 million people just dismantled what we thought we knew. And the way that they did it reveals something important about how we've been approaching heart attack risk all along. So first, let's take a look at the scary findings seriously, because it comes from real research published in credible journals, and it's genuinely alarmed the cardiology community. In 2023, researchers pulled data from 15 studies covering more than 1.28 million patients who'd experienced a heart attack, and what they found was that 11.6% of those patients had none of the 4 standard modifiable risk factors. So again, no high blood pressure, no high cholesterol, no diabetes, and they were a non-smoker. In Australia specifically, that number climbed to as high as 23%. And then there's a troubling twist that made all of these findings harder to ignore. The patients who had no documented risk factors didn't do better after their heart attacks. They did worse. So the short-term death rates were higher in these SMURF-less patients compared to those who had traditional heart attack risk factors. And the working hypothesis was that these patients were flying under the radar of preventative medicine. They weren't being treated with cholesterol-lowering medications or high blood pressure medications because it appeared that they didn't need them. And so they arrived at the hospital in worse shape. And the implication of this was uncomfortable. If up to nearly 1 in 4 of the most severe heart attacks happen in people with no detectable risk factors, maybe our entire preventative care framework was missing something. Maybe
So I think part of this is going to be, are we saying that the thresholds are too high, right? They actually did have some underlying dyslipidemia or insulin resistance, but because we're using diabetes as the cutoff, or because we're using sort of older cutoffs for dyslipidemia as our marker for who has high cholesterol or who does not, or we're using outdated markers like LDL-C instead of perhaps the more informative ApoB, or maybe that we're not even using some of the risk enhancing factors that might capture a significant portion of the population. For example, Lp(a) or hsCRP, high sensitivity C-reactive protein. The American College of Cardiology doesn't consider these huge factors for the population at large, but if we're talking about, and I think it's closer to 10%, truthfully, that I think that 23% is high, and just looking quickly at that abstract, it was only about 3,000 patients with heart attacks that they were surveying, so it's probably a pretty small percentage, a small fraction of a big population, but nevertheless, somewhere in that 10 to 20% range, there may be a bunch of these patients who could be identified if we were looking at risk enhancing factors in addition to the classic markers, and perhaps waiting until patients have diabetes is not the best situation because, for example, we know that even hemoglobin A1C, which is the most common way we diagnose this, under captures patients, right? If we actually used a 2-hour glucose tolerance test or fasting glucose measures, we would capture more people with a diagnosis of diabetes than waiting for their A1C. So I think that, if I had to guess about who we're missing, probably it's that, and probably it's Lp(a). But let's carry on, see what else Brad wants to talk to us about.
Heart attacks really could come out of nowhere. It's an idea that Jim Fixx explicitly rejected. He was confident that if a person didn't smoke and exercised enough, heart attacks were essentially ruled out. And sadly, his own story proved that he was wrong. But was Fixx just an unlucky outlier, or was something hiding in plain sight? Recently, a team led by Dr. Hok-Hugh Lee at Yonsei University in Seoul decided to approach the question of these SMURF-less heart attacks from the opposite direction. Instead of looking at which risk factors patients had documented by the time that they arrived in the emergency room, they looked backwards. They tracked people through the years of repeated health examinations before any cardiovascular event occurred. And the scale of the study is remarkable. They drew on two independent cohorts, so the Korean National Health Insurance Service database, which covers essentially the entire South Korean population, and the multi-ethnic study of atherosclerosis, which is a long-standing American cohort. And together, that's more than 9.3 million people, followed up for more than 13 years in Korea and 19 years in the US. And across those years of follow-up, over 600,000 cardiovascular events, like heart attacks and strokes, occurred. For each person who'd had a cardiovascular event, the researchers went back through all of their available health data. So every recorded blood pressure reading, every cholesterol measurement, every glucose test, every documented smoking history, and they asked, did this person ever have a non-optimal level of any of these 4 risk factors at any point in the years before their event? And here's what they found. More than 99% of people who'd had a first heart attack had at least one non-optimal risk factor beforehand. This was consistent across both countries, consistent in men and women, consistent across age groups from under 60 to over 80. And there wasn't just one risk factor hiding in the background. More than 93% had at least 2. So we've got 2 bodies of research telling us the opposite thing. One says that up to 23% of serious heart attacks happen in people with no risk factors, but the other says that more than 99% had at least 1. So both are published in top journals and both use large data sets.
So this was me jumping the gun again, because it's actually this JACC paper that I am remembering, thinking about the number of patients who've had non-optimal risk factor control prior to their major adverse cardiac event. So again, this was the discrepancy that was in my mind when we started this video. Let's see how Dr. Brad is going to help us reconcile this.
So how could they possibly both be right? Well, here's where the detective work gets really interesting. Because the disagreement between these 2 findings isn't really a scientific contradiction, it's a methodological one. So the 2 sets of studies are answering different questions. The standard SMURF-less research, so they asked, did this patient have a clinical diagnosis of a risk factor? That means, were they ever told by a doctor that they had high blood pressure? Was high cholesterol ever written in their chart? Did they have a formal diabetes diagnosis? That all sounds reasonable, but there are 2 massive problems with it. The first is underdiagnosis. So getting a clinical diagnosis requires that you've seen a doctor, that you've been screened, and one of your readings has reached a threshold where you can now be classified with that diagnosis. In the real world, though, that doesn't often happen. So around half of those with high blood pressure, so the single most common modifiable risk factor for cardiovascular disease, they have not been diagnosed. Low diagnosis rates for high cholesterol and diabetes are also well documented. So if your blood pressure has been quietly running at 138/88, for instance, but you've never had it flag, you showed up in the SMURF-less dataset as no hypertension, but you did have high blood pressure.
So this is a great point about the quality of research data that we have for some of these studies. The point Brad is highlighting is the difference between actually looking at the measured values, right? The glucose measurement, the A1C measurement, the blood pressure measurements in the chart versus what a doctor has written down and diagnosed. Because patients will show up all the time in clinic and say, oh, I know my blood pressure was high today, doc, but it's just because I was late, or I have white coat syndrome, but it's usually fine at home. And then the doctor will say, okay, and sometimes just take the word for it or go from there. This should be validated with home measurement readings and noted as such in the chart. The next step that we often see in big studies is billing data, which is not only the diagnosis that might be written down in the chart, but what's actually coded. So everything that I do, for example, gets translated into a diagnosis code and a work code for the procedures that I do, for example. So it's one thing for me to write down in my notes that the patient has a diagnosis of hypertension, but if I forget to click the box in my medical record that says the patient has hypertension, now we're even one step further removed from the clinical relevant data. And I am usually pretty hesitant to make any changes in my own practice based on studies that are only using billing data. And unfortunately, the biggest data sets we have are billing data. So like the Medicare data set, for example, is predominantly a billing one. Most of the insurance company data sets, like the TriNet data set is one that's come up several times recently in the vascular surgery literature, is all a billing data set, and they can pull pharmacy records, which is nice because you know what the patient's been prescribed, but you don't know if they're taking it. And you don't necessarily have any of the actual numbers in front of you. What was that patient's hemoglobin A1C? We don't know. We just know they have a diagnosis of diabetes. What was their blood pressure? We don't know. They just have a diagnosis of hypertension. So this comes back to the idea of being really, really conscientious about what is the true underlying data set that we're using and how accurate do we think it is.
Second problem relates to the thresholds that the researchers selected to define risk. So cardiovascular risk, it doesn't have an on-off switch. These risk factors operate on continuous, cumulative gradients, meaning that the damage accumulates even at levels that fall below clinical diagnosis thresholds. A blood pressure of 126 on 82, for instance, is not clinical hypertension by any guideline, but it is elevated above what the American Heart Association considers optimal. It can promote plaque buildup in the arteries. And if you've had it for 15 years, that's 15 years of accumulative vascular damage that wouldn't show up in a SMURF-less study because you were never officially diagnosed. In fact, the thresholds used in the SMURF-less literature, they've often been high by current standards. So this study in the Journal of Cardiology defines hypertension as blood pressure of 140 and above. This is exactly why this new study that we've been looking at used stricter cutoff points derived from the American Heart Association's Life's Essential 8 framework. So these targets are associated with ideal cardiovascular health, not just the thresholds that trigger clinical treatment. So non-optimal blood pressure is defined as a systolic blood pressure, so that's the top number, of above 120. A diastolic blood pressure, so that's the lower number, of above 80. Non-optimal cholesterol is total cholesterol above 200 milligrams per deciliter. Non-optimal fasting glucose is 100 milligrams per deciliter or above, and past or current smoking counted, not just current. So as Dr. Lee put it plainly, he said that when they looked closely, these earlier reports of risk factor-free heart attacks might have actually reflected missed risk factor diagnoses or risk factor levels that were non-optimal in terms of cardiovascular risk.
So I want to point out, for example, that fasting blood sugar of over 100 would be a diagnosis of prediabetes, not actually diabetes. And so again, that may help us capture way more people if we are working under this idea that, in fact, insulin resistance, poor glycemic control, hyperinsulinemia might be one of the key driving risk factors for cardiovascular disease in 2026. Because I do think, smoking is never going away completely, but it is becoming a smaller and smaller fraction of the patients that I see and treat. And I think for the cardiologists as well, it's down quite a bit, and yet we are seeing more patients than ever. High blood pressure is always an issue. Again, using that 120 cutoff is much more aggressive. And let's see if we can figure out, again, between metabolic syndrome, right? Elevated fasting glucose, elevated blood pressures. They're interestingly using total cholesterol rather than non-HDL cholesterol or LDL-C. Again, I would say LDL-C and triglycerides are probably the most helpful. Non-HDL is even better than those, or is reflective of both of those. And ApoB would be even better, though that is not yet reflected in guidelines, and we still don't have Lp(a), which again, also not reflected in guidelines, except in the very recent 2026 ACC/AHA new set.
Many of these, with risk factors, have continuous rather than a yes or no relationship with the risk of developing cardiovascular disease. And when they were asked about these striking results, Dr. Lee pointed to the consistency. So he said, surprisingly, the results were almost identical between the Korean and the US cohorts. That consistency across very different populations and very different health systems makes our findings especially strong. The two literatures, they are not conflicting each other. What they're answering are different questions. Was the patient diagnosed versus did the patient have exposure? Different questions.
So I don't think they're different questions. It's actually the same question. It's the precision of the answer, right? They're still all trying to get at, do these patients have poorly controlled risk? The answer, though, is really based on the precision of the data underlying that answer. And when we actually go into the numbers and look at blood pressure measurements, fasting glucose measurements, we recognize that the granular patient level data way outperform what a doctor captures because we gloss over the blood pressure of 129 over 84, right? We gloss over the fasting glucose of 105. often, right? I tend not to, but that's because this is my bread and butter. Nevertheless, in general practice, this becomes a difficult thing. And again, are we actively recommending blood pressure medicine for people who are 128/82 when they show up in the office? No, most people would say that's going to be kind of standard. And, exercise more, eat better, and we'll check again in a year.
And very different answers, which brings us back to Jim Fixx, because his story turns out to be an almost perfect case study in this methodological gap. So a SMURF-less study conducted at the moment of his death might have coded him as risk-free. He'd quit smoking 17 years earlier, so he was a non-smoker. He wasn't a documented diabetic, and he wasn't formally diagnosed with high blood pressure. It looked like a clean bill of health, at least with 3 out of the 4 standard risk factors. But if we apply the new study's methodology, the picture is completely different. Fixx was smoking 2 packs of cigarettes per day when he took up running at the age of 35, and he weighed 214 pounds, significantly overweight by any standard. His father had died of a heart attack at age 43 after a first heart attack at age 35, a family history of premature cardiovascular disease that should have put him in a high-risk category. Then there was the 4th traditional risk factor. His total cholesterol was above 250 milligrams per deciliter, which is well above the 200 milligram per deciliter non-optimal threshold, and elevated even by clinical diagnosis standards. And his autopsy confirmed that all of this might have been predicted. One coronary artery was 95% blocked, a second was 85% blocked, and a third was 70% blocked. And there's one more detail that makes Fixx's story particularly striking. So in December 1983, 7 months before his death, he visited the Cooper Aerobic Center in Dallas. So Dr. Kenneth Cooper, the pioneering exercise physiologist and Fixx's personal friend, urged him to take a cardiovascular stress test, but Fixx refused. Cooper was haunted by this refusal. He told reporters afterwards that he adamantly refused, and that stands out in my mind now. I don't know why he refused. Maybe he had an underlying feeling that he was ill. Friends and family also reported that Fixx was complaining of chest pains during his runs in the months before his deaths, and when physicians looked through his records, these may have been angina episodes. And Fixx's own journal entries, recovered after his death, reveal his denial at work. So that spring, just months before his fatal run, he wrote, "My neurotic blood pressure anxieties, occasioned by feeling intense these past 2 months, are apparently without foundation. Maybe the problem is nothing more than being hypochondria." A cardiologist commenting on this case at the time put it bluntly, the second most common symptom of coronary disease after angina is denial. Fixx had a
I'm chuckling because I actually think that this is an important thing in the vascular disease realm as well. The number of patients who are in denial about symptoms is high. And I don't think it's that they're truly in denial, it's that they're so scared. And they're scared of finding out that they need surgery. They're scared of finding out that they might lose a leg or that they might have a stroke. And I get that. And part of the goal of this channel is actually to help sort of demystify some of these things, but also to empower you to prevent them so that you never, ever need any of those interventions. The other thing that I find fascinating about this is that I've done a couple of videos on the importance of exercise and the relationship between, for example, a high volume endurance exercise and the presence of coronary calcium. And a lot of people show up in the comments saying, "Oh, well, you don't need the exercise. Look at Jim Fixx. Look at Jim Fixx. He died and he was an exerciser." And I haven't actually gone back in depth to look at his history, but Dr. Brad has done a phenomenal job of uncovering all of this. And now, again, in retrospect, of course, right? It had very little to do with his exercise. Probably that kept him alive much longer than he otherwise might have been, given his very strong family history of premature cardiovascular disease. His dad had a heart attack at 35. I am certain that there is either Lp(a) or a strongly inherited genetic component to that, plus 2 packs a day of smoking for a number of years, plus excess adiposity and the inflammation associated with that. So I am not at all surprised that poor Jim Fixx had his cardiac event. And it sounds like there were a lot of reasons to believe that this was, that he would have heart disease. And then he actually had physicians who were trying to, help get him to a place where they could help manage that for him. And unfortunately, that was not something he was interested in.
At least 3 silent heart attacks in the weeks before his fatal one, according to his autopsy. Jim Fix did not lack risk factors. He lacked detected risk factors, and he actively avoided medical engagement that would have found them. His story is not about the failure of healthy living. It's about what happens if you assume that the visible transformation, so the weight loss, the cut out cigarettes, the miles run, is the whole story. And here's what genuinely struck me about this data, because I think the correct interpretation is empowering, not frightening. If cardiovascular events are nearly always preceded by detectable non-optimal risk factors, if the 99% number holds across 9 million people in 2 different countries, then the scenario of a heart attack truly coming out of nowhere in someone with long-term optimal risk factor levels is vanishingly rare. It's not common, it's not increasing, it's rare. And that's good news. It means the framework for prevention actually works when it's applied correctly and early enough. The key words here, though, are early enough. The damage from non-optimal risk factor levels accumulates over the years and decades, and the new study's data proves this by tracking people longitudinally rather than catching them at the moment of a crisis. As Dr. Nathan Wong, who directs the Heart Disease Prevention Program at UC Irvine, he put it when commenting on the study, the problem is that we practice reactive medicine rather than preventative medicine, and that is the real villain in the story, not heart disease itself, but the way clinical medicine waits for risk factors to cross treatment thresholds before acting. That is the
I agree 1,000%, and that is why this channel exists. And I am so glad that Dr. Brad is calling this out for all of us as well. And I agree that this is a message of hope, and this is a message of being proactive with your health. And if you have been following this channel, I think you're probably already on this journey. The other thing that he kind of went quickly past, though, which I think is really important because I see this a lot in my patients, is if you had risk factors before and you have been on this health journey and you are doing really well now, it doesn't mean that we still don't have to be a little bit more aggressive to perhaps calm down everything that preceded your amazing transformation. So I have a lot of patients who come to me after they have lost a bunch of excess fat and they are now exercising and they're now really in tune with their body and their health, and they want to make sure that they're doing well. And they're hesitant to have additional control measures like medications, supplements, or more aggressive lifestyle interventions because they're so much better already than they were. And they're like, isn't that enough? What was it all for if I still have to be on medicine, right? That's not what I did this for. I did this to get off of my meds. And I get it. That's amazing. And probably we can be off way more meds than we otherwise would have been. But we cannot ignore a history of smoking. We cannot ignore 40 years of insulin resistance or prediabetes or diabetes, even if it's in remission. We cannot ignore years of high inflammation, high chronic stress, whatever the case may be. We just have to acknowledge that that is still influencing what's going on the inside of your body in those artery walls, and be realistic about what the options are to manage that in the best and most efficient way possible.
model that is structurally too late. The goal is to keep it optimal, so below 120 on 80 for as long as possible. Now, for older adults, we may accept slightly higher blood pressure readings to make sure that they don't feel faint or dizzy. It's not to get your LDL cholesterol below 100. In my view, it's to get it below 55. To manage your weight,
I think 55 is a reasonable target for people with plaque, people with strong family history, or perhaps some other genetic components like an elevated polygenic risk score, which we have not yet talked about on this channel. We certainly can in the future. Drop me a note in the comments if you want to hear more about polygenic risk scoring as it relates to cardiac disease. The target of 55 for the person at average risk might be a little aggressive. I know that overall, yes, people are saying lower better. And I am also acutely aware that getting there may require a fair amount of medication, and those come with at least the effect of having to be on multiple medications, but also drastic side effects for some people. So I don't know that I think everybody needs to be 55 or lower for their whole life. And yes, I am certainly aware that the lower the better. We did talk about in the recent Ask Me Anything, a case study that I just read where somebody had genetically low LDL-C, like in the 40s for most of his life and still developed plaque because of his insulin resistance. That is a true statement. And so it won't protect everybody in the absence of controlling other risk factors, which I know he's getting to and would also agree is, of course, very important.
and blood sugar levels to use medications like tirzepatide if needed. All of that is a higher bar that most clinical practice doesn't quite aim for, but to me, that is the bar that the data actually supports. But there is a catch here, because even if your LDL cholesterol looks fine on a standard blood test, there's a reason why it might be misleading you. LDL cholesterol of greater than 55 milligrams per deciliter is a real threshold and it captures a lot, but it's a blunt instrument. What actually drives atherosclerosis, so that's the process of plaque building up in your arteries that eventually causes a heart attack, isn't cholesterol mass, it's the number of atherogenic lipoprotein particles. And each particle that can penetrate our blood vessel walls and deposit cholesterol has a tag on it, and that tag is called ApoB. That is a direct count of all of those particles. And the main problem of a standard blood test that most doctors use, so LDL cholesterol, is that it measures cholesterol content carried by those particles, not the number of particles themselves. And those two things can diverge significantly, particularly with those who have got metabolic syndrome, insulin resistance, or elevated triglycerides. So you can have an LDL cholesterol that looks fine, but when you test your ApoB comes back high. Clinical medicine in the past has been slow to adopt ApoB testing because of concerns around cost effectiveness. Adding ApoB, it roughly doubles the cost of a standard lipid panel. So is it really worth measuring something beyond the standard panel? Well, the argument just lost its last leg. A study just published in JAMA modeled 250,000 statin-eligible adults across their lifetimes and compared 3 strategies for deciding the intensity of lipid-lowering therapy. They looked at using LDL cholesterol, non-HDL cholesterol targets, or using ApoB targets. The ApoB-guided strategy produced the most quality-adjusted life years, and it was highly cost-effective. And the 2026 guidelines have now formally incorporated ApoB into its recommendations for the first time in a major US guideline, particularly for patients where LDL cholesterol may underestimate true risk. And
So what I'll say about this is if we are optimally managing your insulin resistance, and he said tirzepatide, which sure, that's a very nice drug for that in people who require it, but there are also things like metformin. There are, drugs that will help excrete glucose. And oh, by the way, let's talk about the nutritional component of how we get there and using both our foundational nutritional strategies and exercise to help us manage our insulin load. I think that is probably where I would start. The idea that your ApoB is going to be very discordant or provide a different answer or target than your LDL-C is unlikely because your triglycerides should be pretty low if we are managing your insulin resistance optimally, right? If you have good insulin sensitivity, your triglycerides should be well under 100, and therefore we're not going to have an excess of remnant particles to contribute to an elevated or discordant ApoB relative to our LDL-C. And non-HDL cholesterol, which you can get on a standard lipid panel, is also something that will tell you that. So I think that you should get your ApoB and your LDL-C measured together at least once or twice and see if you have very discordant results. If you do not, and you are maximally insulin sensitive, I'm not certain that we have to keep following ApoB. He says it doubles the cost of a lipid panel. A lipid panel is, somewhere in the $15 to $20 range if you're here in the US. ApoB is, again, about $18 to $20. So sure, it doubles the cost. It's not an inordinate cost. And it's worth doing a couple of times just to make sure that you're concordant. Once you know that, and once you have maximal insulin sensitivity, I don't think it's necessary to keep track of that over time. If you wish, by all means. But again, the people for whom you see discordant ApoB versus LDL-C are people with insulin resistance who have elevated triglycerides, elevated remnant particles. There will be a few people who have a familial kind of dyslipidemia where they have lots of chylomicrons or triglycerides that are unrelated to their metabolic status largely, but that's a very, very rare percentage, and they will be caught in other screening methods as well. So ApoB is a better tool. It should be checked. Once you are concordant, you can stick with your non-HDL or your LDL and make sure that your targets are appropriate there.
One of the most powerful tools that we've got for controlling our cholesterol levels is tragically underused. So in this next video here, I'll show you the remarkable story about how it was discovered and the data about how big an impact it can make.
All right. Thank you, Dr. Brad. We are going to give that video a like. So I have here the journal the journal article from the Journal of the American College of Cardiology, or JACC. And this is what Dr. Brad was talking about in the video, where he says that over 99% of people who have a heart attack or a heart event have a risk factor that is poorly controlled before the event. So this is what I was thinking of when he initially said that 10 to 23% of folks did not have a risk factor for a heart attack, and these were the sort of SMURF-less people. But in fact, this was something I had already seen, and indeed, in fact, when we look carefully at the data, over 99% of people. But I really want to dive in deep and figure out which of the risk factors contribute the most for patients who have events, and are there any ways to sort of reanalyze the data and see whether there's more interesting stuff here if we dive a little deeper. So I'm going to go through this paper with you. We're going to go through their findings, some of the key figures from the paper, and see what we can learn. So this was published by Philip Greenland and colleagues in October of 2025. And forgive me while I scroll through here. We're going to take a quick peek at this central illustration. So they are showing us, again, as Dr. Brad said, that we have two separate cohorts here. We have the Korean National Health Database, which includes their whole population and is a really strong group because of the fact that there's really no bias here. It's the entire population. They have their lab data, they have their blood pressure measurements, and you could argue, well, that's a Korean population. That doesn't necessarily represent us here in the European and Western, in the United States, for example. But we now have the MESA cohort, the multi-ethnic study of atherosclerosis, which is a really well-validated cohort, largely based in the United States, where we also are capturing large swath of the population and their cardiac events. So the MESA here is on the right. The Korean National Health System is on the left of this figure. And what they're showing you at the top is, does CVD frequently occur without preceding non-optimal traditional risk factors? So we have many, many more patients in the Korean database here, but we have about almost 7,000 CVD events in the MESA cohort, and they're breaking these down for you. So CHD will be coronary heart disease, MI or heart attack, stroke, and heart failure, and then we total all of that to be CVD. Excuse me, so the total CVD is 1.1K in MESA, and the overall cohort was almost 7,000. We have 600,000 events in the Korean out of over 9 million patients. And here again is the criteria that they use for non-optimal risk factor control. So systolic blood pressure over 120, diastolic blood pressure over 80, total cholesterol over 200. We're going to get into the sensitivity analysis and see that they actually also looked at non-HDL cholesterol and LDL cholesterol, which is actually more informative, not surprisingly. Then we have fasting blood glucose over 100, which again, this is a threshold for impaired fasting glucose. This doesn't even meet criteria for diabetes at this level or any treatment for diabetes. And then past or current smoking. And what they're showing you in the bar graph is for each of these different presentations of cardiovascular disease, how many of the patients had one or more of these poorly controlled risk factors. And whichever of these you choose, it is well over 99% had a non-optimal risk factor here. There actually are some blue bars. They're just so tiny because they're all less than 1%. And so they say, given near universal presence of greater than one non-optimal traditional risk factors prior to any CVD, CVD events rarely occur in the absence of antecedent non-optimal traditional risk factors, highlighting the importance of primordial prevention efforts. So let's now take a deeper dive into the paper and see what else we can dig out from the results. So here's just a little bit more in the methodology. Universal health insurance in South Korea. This is their national database. There was originally about 10 million, and they excluded some probably for missing data. Multi-ethnic study of atherosclerosis, launched in July of 2000. In almost 7,000 adults aged 45 to 84 years. The MESA cohort is just a little bit of an older population. The Korean database includes everybody aged 20 years or older, but I don't think that's terribly relevant. Obviously, cardiovascular disease is typically a disease of the older adult population. Outcome definitions here. CHD event is defined as incident heart attack or death caused by coronary heart disease, a total CVD event, incident MI, heart failure, stroke, or death. First occurrence of each outcome was considered. So if they have multiple events, they're taking the first one as the definitive event. Risk factor definitions. Definitions of non-optimal. So how did they get to these thresholds? Definitions of non-optimal risk factors were based on the American Heart Association's ideal cardiovascular health framework, reflecting evidence that optimal levels of risk factors are lower than commonly recognized and treated in clinical practice. So later in the paper, they're going to go to clinical criteria and contrast that with these non-optimal criteria. So again, greater than 120 systolic blood pressure. We went through these earlier. And here's what I want to highlight. As a secondary analysis, exposure to clinically elevated risk factor was defined with higher cut points as often used for clinical diagnosis. And that is a systolic blood pressure of over 140 or a diastolic over 90 or any blood pressure treatment, total cholesterol over 240 milligrams per deciliter or lipid-lowering treatment, fasting glucose over 126 milligrams per deciliter, which is the formal threshold for a diagnosis of diabetes, or that diagnosis of diabetes or glucose-lowering treatment at any point among all available examination visits before the outcome event. And current tobacco smoking at the last examination, rather than just a history of tobacco use. Okay. So statistical analysis, sensitivity analysis. All right, let's get into the results here. I'm actually going to go down to the figures because I think that they're a little bit more illustrative here. So here is the bar graphs. Again, Korean Health Service is on the left, MESA is here on the right. Each of the different event types is its own separate line here with the total all the way at the bottom. And the x-axis is percent exposed to non-optimal risk factors prior to the cardiovascular event. So the headline here is for total CVD events. I'm looking here at the bottom row, were at least one non-optimal risk factor prior to the event. 99.3% of patients in the Korean data set and 99.5% of patients in the MESA cohort had at least one non-optimal risk factor prior to their CVD event. And if you want to break this down, the vast majority of that is elevated blood pressure. So 94% in MESA, 95% in the Korean Health Service had elevated blood pressure readings prior to their event. Non-optimal cholesterol is in between 73 and 77%, depending on the cohort. And non-optimal glucose is actually higher in the Korean data set at 75% and about 56% in the MESA cohort. And past or current smoking is about half of patients in the Korean data set and about 60% in the MESA cohort. So let's now keep going and take a look at how many had one or more risk factors, because I could see how you would say, well, this is maybe a bunch of people who just had one slightly elevated blood pressure reading at any time in their prior history, right? Somebody came in one day late for their appointment and they got a blood pressure that was like 124 over 83, and like that was, the one thing. But in fact, if you go look at this, we're now breaking this down by how many risk factors did they have prior to the event. And if you're, again, I'm going to go down here to the total, because I think that's, again, probably the big picture for everybody, whether you're worried about heart attack, heart failure, stroke. Let's combine them all and just take that into account. The number of people who had just one non-optimal risk factor is about 5 to 6%. So you say, okay, 99% of people have at least one non-optimally controlled risk factor. And you want to say, well, one is just not quite good enough because it could be a total one-off. Okay, so take away 5 or 6%. We're still well over 90% having, and up close to 95% having more than one risk factor that would predict or at least highly be associated with the likelihood of some kind of cardiac event. So about 20 to 27% had two non-optimal risk factors, But if we're going to say 3 or 4, now we're well into the 60 to 70% range. So 43% in the Korean and 41% in the MESA cohort had 3 non-optimal risk factors, and 25% to 30% had 4 non-optimal risk factors. So again, the point here is that this is not really an unpredictable scenario. If we're thinking about this at the optimal thresholds rather than these clinical thresholds, then we say, okay, this actually makes sense, right? We know these people have probably metabolic syndrome because of the high blood pressure and elevated cholesterol. Like some of that's going to be their triglycerides. And again, the glycemic control is not as prevalent here as I would have expected, but it is definitely a big part of the associated risk, especially as it might be translating into poor blood pressure control. So let's keep going here and see how much of this is related to age. So this is a breakdown of each of these cohorts, again, by each of the event types. And now we're looking at, well, is age a hugely important factor? Are we only seeing this in the older patient groups and it's not helpful in younger patient groups? And the answer to that is, even just visually, you can see, no, this applies to all age groups, even if we're looking at folks under 60 years of age. Let's go again down here to the total CVD event cohort or group here. Under age 60, we're still seeing 99.7% in the Korean group and 95.4% in the MESA cohort having at least one non-optimally controlled risk factor prior to their event. And yeah, as you get in the older groups, we are now up in the 99% range in both data sets, but this is, again, not something that is only explained by the fact that risk factor control seems to loosen a little as adults get older and we determine that it, for example, blood pressure, we tend to be less aggressive controlling that in people over the age of 80, because if we are too aggressive, when we drop their blood pressure too low, the risk for falls becomes high, and that's a bad event. So we try not to do that. And again, this is just going to show you that no matter where you are in life, these risk factors are important and do predict your risk of heart attack, stroke, or any cardiac issue. Men versus women in MESA, we're still seeing high levels of prediction here. So again, this is actually now by age and sex. So again, the older we are, a little bit stronger, but even men and women under 60, 98% in men under 60, 96.6% of women under 60 in the MESA cohort have at least one non-optimally controlled risk factor prior to their CVD event. And now we're going to look at the higher clinical criteria. This means rather than a systolic blood pressure of 120, we're now going to bump that up to 140 and say, if we're just going to use the criteria that a lot of doctors in regular practice are using to make these diagnoses, we're going to move away from a fasting glucose of over 100 and bump it up to 126, which is the threshold for diabetes, rather than just impaired fasting glucose. Let's take that up and see how many people at this, slightly more relaxed set of thresholds would have this, right? Is it just that we're going to be getting too neurotic about these thresholds? And what you see is that we're still we're at 90% or greater. So if you, again, let's come down here to the total. Prior to total CVD event in the Korean cohort, it's 90.7%. And it is 93.2% for the MESA cohort. So again, slightly more relaxed. We still see that we can largely account for the CVD risk based on these non-optimal or these clinically elevated risk factors, okay? And again, here's the breakdown. Elevated blood pressure was the majority, so 74% in the Korean cohort, about 84% in the MESA cohort. The next risk factor is clinically elevated cholesterol at about 51% in both. Clinically elevated glucose in 40% of the Korean cohort and 30% of the MESA cohort, and active current smoking in 23% of the Korean group and 16% of the MESA group. So again, the clinically elevated glucose is coming down, right? This was about 50% when we looked earlier. If we had the more strict threshold, now it's much lower, and current smoking rather than former smoking is also significantly lower. Interestingly, blood pressure, has come down, but it's still quite high, and the clinically elevated cholesterol is also still quite high. The sensitivity analysis here I want to go through because I don't have a figure for this, but I think this is actually important and interesting, particularly if you're interested in the lipid component of this. So they say when non-HDL cholesterol greater than 130 was used instead of elevated total cholesterol as one of the non-optimal risk factors, prevalence of at least one antecedent non-optimal risk factor was even higher, ranging from 99.5% to 99.9%. So again, this is taking into consideration the fact that non-HDL cholesterol accounts for the atherogenic or plaque-forming particles, right? That is triglycerides and your LDL-C. Because again, we're taking away HDL from total cholesterol and left with the atherogenic particles. It is another proxy for ApoB. Again, not quite the same because we're still measuring the cholesterol rather than the particles carrying the cholesterol, but it's a better proxy than total cholesterol. And I would expect that to be more informative, and indeed it is. And they also say with lower lipid cut points, like non-HDL cholesterol greater than 100 or LDL cholesterol greater than 70, prevalence reached 100%. So again, if we are using better lipid measures and stricter lipid thresholds, we actually see significantly improved performance of this non-optimal risk factor control as a way to understand who may be susceptible to these cardiovascular events. Second, when only the first subtype of CVD event was analyzed as the outcome of interest, prior exposure to at least one non-optimal risk factor were similarly universal. Results were consistent for death from CHD and from CVD, analyzed as separate subtypes. And fourth, the results were identical in a less exclusive Korean national health sample, removing only participants with no data on one or more risk factors at any visit during follow-up. So this was, the last bit of that was just them sort of messing with the data to make sure that this is a robust finding, and indeed it is. So we're going to go back to this central illustration and just say, the stuff that we talk about here all the time, the boring stuff, make your blood pressure normal, make your lipids boring, don't smoke. And if you have a history of smoking, recognize that that is going to impact you for the rest of your life. And it is what it is. It's okay. We just have to acknowledge that there has been impact, right? This is a disease that forms. The plaque forms over decades. The injury to the arteries may continue at a smoldering level, even if you have rearranged your whole life and gone on this health journey and done all the right things, right? Just like Jim Fixx, we may still have some residual risk from stuff that happened earlier in life, and it's okay. We just have to acknowledge that that is still playing a role on the inside of our arteries. I hope you found this deep dive of the paper helpful. I found it really interesting, and I think it's hugely validating for those of us in the prevention space to continue doing what we're doing. And even though I love the idea of making sure that everybody gets an Lp(a) measured and that everybody gets an ApoB measured and that we're following HSCRP and dealing with visceral adiposity and all of the stuff, right? Clearly, if we just stick with the boring big risk factors, that is huge amount of information, and all the rest of this stuff, you can understand why it's a risk-enhancing factor and not necessarily something that is central to our understanding of who's going to get plaque and have an event. So let me know what you think about this in the comments. Back to the video. I don't know if we need back to the video, but there you have it. Awesome. Until next time, guys, take really good care.